Hello, I'm Mackenzie Bredowich. Thank you for joining us and being a part of BIANJ's annual seminar. Before we get started, I'd like to remind everyone to enter your full name in the chat box below. This is our virtual sign-in sheet. If you're going to request CEUs, remember that you must attend this workshop in its entirety, complete the workshop evaluation, and if required by your discipline, complete a post-test. I will be entering that link in the chat for your convenience. Zoom will provide a report of how long each of you stayed in the workshop. CEUs cannot be given if attendance is not verified. Questions are encouraged. Please enter your questions in the chat and they will be addressed at the end of the presentation. This workshop is negative attributions and anger after brain injury, risk factors, assessment, and implications for treatment. Our presenter is Dawn Newman, PhD, FACRM. Dr. Newman is an associate professor at Indiana University School of Medicine in the Department of Physical Medicine and Rehabilitation, and the research director at the Rehabilitation Hospital of Indiana. She has a PhD in rehabilitation science from SUNY Buffalo and her MA in psychology from Rutgers. Her research aims to advance the understanding and treatment of social cognition and emotion dysregulation deficits after traumatic brain injury.
Thank you so much, Mackenzie. Welcome, everybody. So glad that you're here today and thrilled to be a part of your conference today. I truly wish it was actually in person. I was just speaking earlier before the session got started. I'm actually originally from New Jersey, so it would have been really super nice to actually have been there and get to visit my hometown. It's been a while since I've been home. But anyway, hope all of you guys are doing well. I'm thrilled to be able to present some of the research that I've been doing in understanding anger after traumatic brain injury with respect to negative attributions. First off, I just want to mention that this is a series of research that has been funded both through the National Institute on Disability Independent Living and Rehabilitation Research, as well as NIH. I'm very grateful for their support. The objectives for today's session are basically going to be to give you some background and understanding as to what negative attributions are, what negative attribution bias is, and understanding their relationship to anger and aggression after traumatic brain injury, to describe a new pilot study that we just finished testing, an intervention for dealing with negative attribution. So it's pretty much hot off the press. And then also describe some of the measures that can be used to evaluate negative attributions after traumatic brain injury. So I assume I'm preaching to the choir here. Most of you guys attending this conference and particularly this session are well aware of how prevalent anger and aggression are after traumatic brain injury, and that these anger and aggression are often identified and continue on many years after brain injury. So it's often a chronic issue. And when you think about in the scheme of things of all of the different emotional and behavioral issues after brain injury, it is one of the most commonly reported. And also probably one of the most disruptive as well. When you think about trying to get back into the community and dealing with kind of recovery and care after your brain injury, when an individual has issues with anger and aggression, it can really interfere with their ability to participate in rehabilitation. It could present lots of challenges for the individual to be able to return home. It also can cause a lot of stress on the family members as well, and particularly cause difficulty, marital difficulty and relationship problems. And it could also interfere with being able to return back to work, as well as being able to maintain employment if somebody has issues with anger and aggression. Despite all these challenges with anger and aggression and how common it is after traumatic brain injury, there really are relatively very few evidence-based interventions for treating anger and aggression after brain injury, which is probably one of the reasons why we see it so often many years post-injury. And I think that there's probably a variety of reasons for that, but anger and aggression is quite complex, right? And then obviously with brain injury, there's probably lots of different reasons contributing to that anger and aggression, and it's really not a one size fits all. And we truly need to do a better job of really understanding kind of what are those mechanisms and contributions as to what might be contributing to somebody's anger and aggression after brain injury. And so that led to some of the research that I've been doing on attributions after traumatic brain injury, and examining this for the first time in people with traumatic brain injury, empirically, an empirical investigation of negative attributions and something called the attribution emotion theory. Some of you may be very familiar with negative attributions. For those of you who aren't, essentially attributions are our appraisal, our judgment of other people's actions. Every time we're interacting with people in our world, our environment, we're always evaluating people's actions and trying to understand and make sense of why people are doing what they're doing. But imagine for a moment you're in a restaurant, in a fancy restaurant, and you're all dressed up, and a waiter comes by and spills huge glass of wine all over your best clothes. Um, Imagine we're judging that waiter's actions. We're trying to figure out, did the waiter do this on purpose? Was the waiter's behaviors hostile or malicious? And how much blame do we ascribe to the waiter for what happened? And this may or may not be going on consciously in our head, but these are things that are happening maybe sort of in the background. Um, well, the attribution emotion theory basically states that the degree to which we are assuming or appraising people's behaviors as intentional or hostile or to blame for the consequence, these attributions are strongly correlated with how we're going to feel in response to the situation. So, and particularly how angry we're going to feel in response to that situation. And this relationship has been well established in individuals without traumatic brain injury. And it makes a lot of sense, right? To assume, well, if I think somebody did something to me maliciously, then, well, no kidding, of course, the increased anger that there's going to be. So that's not really groundbreaking or rocket science. So I think where this really becomes very interesting is that there are individuals who are prone to this negative attribution style thinking when it's not in fact warranted. So thinking about situations where somebody's actions, the intent behind their actions is not clear, where it's ambiguous. Um, Individuals may be more inclined to ascribe extreme negative attributions that are not warranted to that situation or are disproportionate to what the situation typically would warrant. So if you think about kind of when you're raised, for the most part, we're kind of taught to give people the benefit of the doubt, but somebody with a negative attribution bias is not going to be likely to give somebody the benefit of the doubt. If there's any uncertainty or lack of clarity, somebody with a negative attribution bias is going to be more inclined to lean on that side that there was hostile intent behind that. And this negative attribution bias is often associated with social misconduct behaviors, aggressive behaviors, and domestic violence. People with various affective disorders, including schizotypal personality disorders, conduct disorders, and criminal offenders frequently are observed to have negative attribution bias. But this is not something, this negative attributions, this association between the attributions and an anger response and negative attribution bias is not something that has been examined in traumatic brain injury. And what I should mention is that when we look at in the literature outside of the TBI world, looking at negative attributions and negative attribution bias, it has been associated with cognitive deficits, trait aggression, and social cognition problems, which, as we all know, people with traumatic brain injury are susceptible to. So it's likely it makes sense. There's rationale to believe that somebody with a brain injury may also have this negative attribution bias. So this prompted us to conduct a series of studies investigating this in TBI, in the TBI population for the first time. Throughout the series of research, we were looking at one, to examine whether or not this relationship between attributions and anger is something that exists in people with TBI. We also wanted to know whether attributions was associated with an aggressive behavioral response, because if somebody's getting angry, but it's not affecting their behavior, maybe it's not that much of a problem. So we wanted to be able to look at that association as well. We wanted to see if people with TBI do have a bias for negative attributions, and then whether or not what risk factors would increase one's likelihood or tendency to make these negative attributions, and then can negative attributions be treated? And then also, what are different ways in which we can measure negative attributions after brain injury? So with the first study, as I said, we were interested in examining this relationship between negative attributions and anger. So is anger after traumatic brain injury associated with the attributions that they make about other people's, the intention and the hostility and the blame about other people's actions? So in this study, we to measure attributions, we used the Epps hypothetical scenarios. So these were scenarios created by James Epps, and essentially they are 21 written scenarios. And essentially what these scenarios do is they describe a character in the scenario, and the character's behaviors lead to some unpleasant outcome for the reader. Now, a third of those scenarios describe the character's behavior where the character's behavior is clearly very benign, although it led to an unpleasant outcome. A third of those scenarios describe the character's behaviors where it's very unclear, so they're ambiguous. And then a third of them describe the behaviors where they're clearly very hostile. And as I said, this was a written narrative, and the narrative is at an 8th grade reading level. And so after reading each one of those scenarios, the subjects were asked to rate how angry they would feel in response to the situation, how intentional they felt that the character's behaviors were, how hostile the character's behaviors were, and how much they blamed the character for the outcome. So these are the results looking at that relationship. So on the x-axis, you have the anger, and the y axis is their attribution rating. So what you're seeing here is the stronger their attribution ratings, the stronger their anger ratings were. So this was these relationships were very strong, significant relationships between their attribution ratings and their anger response. So we found consistent with what has been shown in the non-TBI literature, establishing support for this attribution emotion theory in people with traumatic brain injury. Okay, so next up, we looked at whether or not these attributions were associated with aggression in people with traumatic brain injury. And to do this, we used a different measure, a measure called the Ambiguous Intentions Hostility Questionnaire, or the AIHQ. And this questionnaire has 15 scenarios. Similar to the Epps scenarios, they do describe scenarios that are either ambiguous or benign or hostile. And here you actually have an example in front of you of what one of those scenarios are. So you've been looking for a parking spot for a while. When you see one up ahead, you proceed toward that spot, but someone passes your car and takes the parking space. So then the person is asked, what do you think was the real reason why the person in the other car took your parking space? And that's an open-ended question, and it's meant to identify interpretations of hostility of that person's behavior. So how hostile was that person's behavior based on the reasoning for why they did what they did? Do you think that the person in the other car took your parking space on purpose? So that's a question about intent. How angry would this make you feel? How much would you blame the person in the other car for taking your parking space, and what would you do about it? And this last question here, that's aimed at getting at how aggressive would your response be if this were to happen to you. So you have to kind of have some insight and sort of project what you think you would be feeling and how you would respond in this situation. And so in trying to understand this relationship between attributions and aggression, we were interested in looking at those attributions A, B, and D with respect to the responses for E. So we do have these two open-ended questions. And so we did have two independent raters score the responses to these questions. They were also blinded. We did in this study, we did have people with TBI and people without TBI. So our raters were blinded to who had TBI and who didn't. They were also trained by the author of this measure, Dennis Combs, as well. And there was high interclass correlation amongst the raters for these open-ended responses. So what did we actually wind up seeing? So are these attributions related to aggression? So here in this first column, what we're seeing is their attributions of intent and hostility and blame were moderately and significantly correlated with their aggressive responses to this AIHQ item. What would you do in response to this situation? We also were interested in, aside from their aggressive response to this AHQ, we also tested them, we gave them a trait aggression questionnaire. So we used, it's a standardized measure for trait aggression, the Bus-Perry aggression questionnaire. And what we wound up seeing is that there was a correlation between their attributions and their trait aggression on this measure of a weak to moderate level, but these relationships were in fact significant as well. So yes, attributions are related to aggression. Okay, so in this next study, I'm sorry, you're probably hearing my cat crying because the cat is locked in the room. Sorry about that. Anyway, maybe she'll make a guest appearance. So this third study, what we were looking at was whether or not people with brain injury were prone to a negative attribution bias. And so the way in which we did that is we compared negative attribution ratings in people with and without traumatic brain injury, with the idea that if their attributions were more extreme, and for people with traumatic brain injury than their non-injured peers, that this would be an indication of a bias showing, that they were elevated compared to what the typical norm would be. And we did, so in the study, what we wound up finding is, so these are their attributions of intent, comparing our participants with traumatic brain injury compared to our healthy control participants for all of the scenarios combined, looking at just the benign scenarios, the ambiguous scenarios, and then the hostile scenarios. And you can see across the board, regardless of the type of scenario, we saw that our participants with traumatic brain injury rated the characters' behaviors as significantly more intentional than their healthy control peers, indicating a bias there. And then we saw the same exact pattern for their attributions of hostility. Again, they rated the characters' behaviors as significantly more hostile than their healthy controlled peers, regardless of the type of the scenario. And then the last one here for blame, the same exact pattern we're seeing here as well. And then we also looked at their anger response ratings, and as we suspected, we also saw that their anger, that individuals with traumatic brain injury reported that they would have felt angrier compared to their healthy controls in response to these scenarios, which makes sense given that significant relationship between anger and attribution ratings. Okay. So, so obviously this is an issue. What are the risk factors that would contribute to somebody having these negative attributions? What would make somebody more likely to ascribe more negative attributions to somebody else's behavior? Okay, so this is a breakdown of the demographic demographic information and the injury information for our participants. You can see that so this was, we had a sample size of 105 people with traumatic brain injury. We had recruited people from 2 sites, from Indiana University, also from Tier in Houston, along with Baylor College of Medicine. So we had, on average, individuals were around 40 years of age. Interestingly, we had a fairly balanced group of males and females. So 57% were males. On average, participants were had about 14 years of education. Our group was predominantly white, followed by Black. In terms of years post-injury, on average, people were 5 years post-injury. And then their injury severity, it was consistent with more moderate to severe injury, TBI. So the factors that we examined in the models, essentially, so when I say the models, we're trying to understand putting all of these potential risk factors in a model to see what factors are indeed associated with these more negative attribution outcomes. So in these models, we put in all of the factors when we looked at it, just looking at kind of the straight correlation with these outcomes. Anything that was significantly correlated, we included in the model. So that included demographic information for education, race and ethnicity, and employment. For the cognitive factors, we included information about verbal fluency, both for letter and category fluency, outcomes for the Stroop. Perspective taking, we used something called the Interpersonal Reactivity Index. It's a subjective measure of perspective taking. And then we evaluated social inferencing with the awareness of social inferencing test, otherwise known as the TACIT, created by Skye McDonald out of Australia and her colleagues. And this measure has 3 subtests where participants it's a video-based test, and they're shown these videos. And for the first part of the test, they're just asked to evaluate the person's emotions from their nonverbal cues. Then the second and third parts of the test are more advanced social inferencing, where they're shown exchanges between 2 characters, and they're asked to make inferences about what the characters were thinking, what they were trying to say, what they were trying to do, and how they were feeling. There's a difference between the parts 2 and parts 3. Part 2, which is the minimal condition, versus part 3, which is the enriched condition. The minimal condition, the exchanges that you're seeing are either sincere exchanges or sarcastic exchanges, and there's only minimal context available to make these inferences. For the latter one, the third sub-test, where there's an enriched context, it was also the exchanges were either sarcasm or lies. So it's there's increased complexity and more contextual information. So it's a little bit more advanced and difficult. Then the final factor in cognition is alexithymia. For those of you who have not heard that term before, that means you've probably never met me, because this is my other area of passion in my research. So alexithymia literally means no words for emotions. And it essentially, people who have alexithymia basically have poor insight to their emotions. They may not recognize when they're having an emotional response, or if they do recognize that they're having an emotional response, they're less likely to be able to label or differentiate the one emotion from another. And it's quite common in people with traumatic brain injury, and has been associated with anger and aggression after brain injury. But it's a cognitive, emotional processing of your emotions. And then we also looked at emotional factors. We looked at trait aggression, and then we looked at anxiety. While we did look at depression, we did not include that in the model, because we could not include factors in the model that were highly intercorrelated with one another. So there was more support in the literature to include anxiety over depression in the model. So this slide is a little bit busy, but essentially, so on the left-hand side, you have all of the factors that went into the model of being able to look at its association. So there were 3 models, one for intent, one for hostility, and one for blame, and looking at how all of these factors, when put in the model at the same time, are associated with these attribution styles. So what we wind up seeing is that, as one would suspect, that trait aggression was significantly associated with all 3 attributions. Then we wound up finding that social inferencing for the enriched scenarios was significantly associated with attributions of intent and hostility. And then being Hispanic ethnicity was marginally associated with, there was a trend towards association with hostility. So these are factors if you're thinking about a client or a patient who has attributions, who may have negative attributions, you may want to be thinking about some of these things. Or if you have patients who do have social inferencing problems, or you suspect there may be trait aggression issues, you may be thinking, okay, maybe this person is going to be more prone to having negative attribution style thinking, and this might be contributing to their anger. Okay, so then that brings me to, so how do we treat negative attributions? And so it was really interesting. I tell this story a lot because it's probably one of my favorite and most flattering stories, because I've been doing this research now. Gosh, it's crazy to think about it, but it's this whole series of research from the beginning of establishing that first relationship between attributions and anger, I think started back in 2012 or 2013. And I wound up speaking on the results of that first study at a conference in the Netherlands. And after I gave that presentation, a neuropsychologist and a speech pathologist came up to me afterwards, really excited about this study, and said, this, really captures so many of our clients with brain injury. I feel like this really explains a lot. This makes so much sense. And we're going to go home and we're going to create an intervention for this. And I'm like, that's awesome. I'm like, there's no better, thing that a researcher wants to hear, that a clinician's going to take the information that you give them, and that a clinician's going to go home and apply it and implement it. So anyway, so they went home and they did this. They put together what they had called at the time a perspective training intervention. At the time, we didn't have these factors. We didn't know what factors were associated with these outcomes, but the way they sort of evaluated the situation, they're like, they really, what's important is to be able to put yourself in somebody else's shoes and understand where other people are coming from. So they created this intervention, and they did a case study on 2 individuals. It was a group therapy with these 2 individuals, and they looked at anger and aggression several times before they did the intervention, and then after they did the intervention. And these were individuals that were like 20 plus post-injury, extreme anger and aggression problems. And after the intervention, their anger and aggression levels were at normal level. So it's really very exciting. And so, so we wound up publishing this study, and then I said, hey, do you mind if we take this to the next step to evaluate this more rigorously? And she's like, please, absolutely. So we wound up doing that and applying to NIH for an NIH grant. We renamed the intervention to Intervention to Change Attributions That Are Negative, or the ICANN intervention. And the objectives of this pilot study, it's a phase 1 randomized waitlist controlled trial to examine the early efficacy of this group therapy program, now called ICANN, at reducing anger after brain injury. And so there were a series of questions that we had asked that we were interested in answering. One, what is the feasibility of this intervention in terms of looking at attendance, satisfaction, adverse events? We also want to know, with this intervention, do participants' attributions become less negative? Does it change their perspective taking? Do they have better perspective taking? And then, are there reductions in their anger and aggression, which is obviously the most important and was the primary outcome of this research. So as I said before, this was a randomized waitlist controlled trial. And again, it was a group therapy. So what we did is we recruited participants in 4 consecutive waves. So we had screening, otherwise known as T0. After somebody came in for screening and were found eligible, they sort of went in this waiting pool until we accrued a certain number of participants, at least 6 participants. And then once we had a minimum number of participants, we then brought those subjects back in. That would be a wave. And then we did some T1 testing with all of the subjects in that group. Then we would randomize them to either to ICANN or to waitlist control. If they were randomized to ICANN, they started the intervention pretty much the following week. If they were randomized to waitlist control, they didn't have anything. After that it was the intervention itself was 6 weeks long. So at the end of that 6 weeks, both groups, the ICANN and the waitlist controls, came back for time 2 testing. And then after that time 2 testing, the waitlist control group received the intervention. And then the waitlist control group participants were tested again at time 3. We did not test the group that was randomized to ICANN another time due to sort of timing and funding restrictions. So all of the subjects received the intervention. So our outcome measures, we evaluated satisfaction with a client satisfaction questionnaire. We looked at anger and aggression with a variety of measures, again, because this was a pilot study, sort of seeing what would be the most robust. Our primary outcome measure we used was the Buzz-Perry aggression questionnaire. We also used the PROMIS anger. We also looked at outcomes on the EP scenarios. We looked at perspective taking on that interpersonal reactivity index again, which is that subjective measure of perspective taking. And then we, not sure if you guys are familiar with it, but the global impression of change. We used that scale to evaluate participants' global impression of change, both for perspective taking and anger separately. And then we had subjects themselves report on that, as well as their care partners or their caregivers report on this global impression of change to get an evaluation from an outside perspective. Okay, so here's the inclusion criteria. Essentially, people had to have a complicated mild to severe TBI. It'd be at least 1 year post brain injury, be on stable medications, have adequate reading comprehension due to the assessment measures. They also had to have above average anger and aggression on the Buzz-Perry aggression questionnaire. And then they had to have impaired attributions and or low perspective taking scores. And we did this because, again, from going back to the beginning of this session, I had mentioned, anger and aggression isn't, treatment shouldn't be a one size fits all, where everybody's going to have anger and aggression for different reasons. And we wanted to make sure if this is the intervention that that people were going to be a part of engaging in, that their anger and aggression was likely to be related to these negative attributions. Yeah. Also, I think also participants could not have been participating in any other type of therapy related to anger. And you can see other exclusion criteria there. But I don't want to spend time reading off what's on the screen that you can already read. Here's our concert flow diagram. So we wound up screening 48 participants. 28 of those were found to be eligible. In between that T0 screening and that time when we're accruing subjects for that wave, we did lose 4 of those subjects. So we were able to bring back 24 of those 28 eligible subjects, and those 24 subjects were then randomized. 10 were allocated to the ICANN intervention and 14 were allocated to the waitlist control group. In terms of completion, we had 8 people that came back for time 2 testing from the ICANN group and 13 people that came back for ICANN for the testing from the waitlist control group, and they continued through to the end of the study. I do want to highlight the fact that this study, a bulk of the study happened during COVID, which presented significant challenges, and there was a massive pause. I think in between wave 3 and wave 4, we were trying to conduct our last wave, and COVID hit and everything had to kind of go on pause for quite some time, which really made recruitment quite difficult. And I guess I didn't mention at the beginning, I probably should have, our initial sample size goal was 40 participants. So this is, so the amount of participants we were able to enroll is significantly underpowered for what we had originally intended upon. So as far as a description of the intervention, as I said before, it was a 6-week intervention. So there were 6 sessions that were 2 hours each, delivered once a week for those 6 weeks. The first session started off with some brief psychoeducational information about anger and attributions after traumatic brain injury and basic introduction. Every session included the following. One, it included a review of the ICANN core principles. It was sort of our mantra, I guess. So I can put myself in someone else's shoes. I can change my perspective. I can change how I think about others' actions. I can change how I feel about others' actions. I can change how angry I get about others' actions. And I can change how I react to others' actions. So after repeating our mantra every session, there were 2 key exercises that happened every day, every session. The first was role playing with video scenarios. So the video scenarios are very similar to those EP scenarios or the AIHQ scenarios, but this time it's video scenarios. They were like short YouTube video clips that were like 30 to 60 seconds long, maybe showing somebody in a parking, in a parking lot, and somebody was going to go, you were going to take that parking spot, but somebody else came in and took that parking spot ahead of you. After watching the scenario, the subjects individually generated ideas for why that person behaved the way they did, the character in the scene behaved that way. Then the group all worked together and they group brainstormed to generate ideas to explain the person's behavior. They then went through all of the reasons that they went up with and selected the most benign rationale for the person's response. And then they took turns role-playing that scenario. So they role-played the scenario being the victim, but in their mind, applying that benign assumption of the other person's actions. And then they processed how they would have felt, how they felt after originally watching the scenario, and then how they felt after applying this benign interpretation of the person's actions. The next exercise is kind of what we refer to as perspective positioning. If anybody in the audience is familiar with the Gestalt 2-chair technique, this is very similar, but a modification of that. What we did is our subjects had to come in being prepared with a personal experience in which something happened to them where they felt wronged or they were upset by somebody else's actions. And in this perspective positioning exercises, it was an experiential exercise where they started off in chair 1 as themselves, and they would have to convey their thoughts and feelings associated with the situation that happened to them. And then they would shift to chair 2. And when they shifted chair 2, they embodied this other person. They became this other person and conveyed thoughts and feelings as this other person. And they would move back and forth from chair 1 to chair 2, working out their thoughts and feelings about this scenario. And it was really very interesting because as we were practicing to do this, getting going over kind of the training before we launched the actual study, it's such a powerful experience. And it's like, as you go through this, it's hard to imagine how powerful it is unless you're actually there and doing it yourself. And you realize once it happens, it's like this light bulb moment and something goes off. And all of a sudden, it's like you realize why somebody did what they did and why they acted that way. And that it wasn't out of maliciousness, but it was these other surrounding factors that contributed to that person's actions that somehow make it more acceptable. Um, so really interesting. I should mention that this intervention was co-led, always co-led by two facilitators. There was always a neuropsychologist in the room, and then we also had a speech pathologist that was also, so it was either it was either a neuropsychologist and a speech pathologist or two neuropsychologists that conducted the intervention. So in terms of the results, so just to show you kind of the characteristics of our subjects, the waitlist control and ICANN subjects, on average participants were in their early 40s, predominantly male. We had a small percentage of participants who had a Hispanic origin. Most of our participants were white. I do apologize in terms of the injury characteristics. So we do see that the injury characteristics are consistent with more moderate to severe injury, as we can see from the most of our participants having PTA for greater than a day. I should have had Glasgow Coma Score scale here for you, but I realized last minute there was an error in our stats. So I apologize for that. But most of our subjects had pretty significant injuries. In terms of what we found for feasibility attendance, 76% of our participants attended 5 or more sessions. It's very difficult running a group. This is my first group therapy intervention, and it is one of those things where it's hard to find a time that fits and works for everybody. And then several of our subjects had work conflicts, so it was really interesting because they probably should have never committed to the study to begin with, but really wanted to be a part of the study. And then afterwards, it turned out the work was too much of a conflict. Then people going out of town, vacation, etc., became issues. We did have several AEs. Most of them are unrelated. We did have 2 that were probably related. We did have one of our subjects. Again, we are recruiting people who are angry and aggressive. They were described very clearly what the intervention was going to entail, but this one person, when they got there and they were explained again the intervention, and they were able to see firsthand what they were supposed to be doing and the exercises that were part of the sessions, they did not they had an initial reaction where they were very opposed to participating in the role play and the positioning exercise, although ultimately they later on wound up doing it and being very amenable and had a great response. But initially that reaction was pretty intense to it. And then another subject did report afterwards, after one of the sessions, that they had some perseveration about the experience that they were sort of playing out, that personal experience. And so, that could happen. For the most part, what we did after all, I forgot to mention earlier that after those personal experiences, we would do a 1-minute calming exercise to bring people down, because it was very emotionally eliciting, again, because it was an experiential exercise. However, for this one individual, it was the person was still kind of thinking about it after they went home. Satisfaction scores, we found that 90% of them reported being mostly to very satisfied, and 95% felt that the services that they received helped them to deal more effectively with their problems. Okay, so getting to that question about are we changing their negative attributions with this intervention? So this first column here is looking at comparing the groups, the participants who were in the ICANN group to the waitlist control group at time 2. So this was before waitlist control received the intervention. So we wound up seeing that the ICANN group, their attributions of intent were significantly lower than the waitlist. Well, not significantly, I guess it was borderline. There was a trend towards it being significantly less negative than the waitlist control group. with medium to large effect sizes. We did not see group differences on the attributions of hostility or blame. I do want to mention we only had 8 people finish the ICANN group and 13 people finished the waitlist control group. So we were significantly underpowered in this study. So that's why what we wound up doing was we wound up pulling together the ICANN and waitlist control subjects, looking at their pre-post intervention changes in their scores. And what we wound up finding is that post intervention, even the waitlist control group getting that intervention, we saw significant reductions in their attributions of intent and the blame attributions with medium to large effect sizes. When it came to our perspective taking measure, that interpersonal reactivity index subjective measure, we did not see significant changes on either the group comparisons or the pulled pre-post comparisons there. However, as I mentioned before, we did do the global impression of change score, both for patients as well as caregivers. This first column is for the patients. So with this global impression of change, subjects had to select which of these 7 options describe their global impression of change for perspective taking. No change, almost the same, but hardly any change at all. A little better, but no noticeable change. Somewhat better, but the change has not made any real difference. Moderately better, and a slight but noticeable change. Better, and a definite improvement that has made a real and worthwhile difference. A great deal better, and a considerable improvement that has made all of the difference. So I'm really interested in 5 through 7 because that's where we're seeing noticeable change. And we saw that 83% of our subjects reported a noticeable change in their perspective taking. And then when we looked at the caregiver responses on this, their global impression of change, we saw about 40% of the caregivers found that reported a noticeable change in perspective taking on the person's perspective taking. Next, we were interested in anger and aggression. And again, this is the primary outcome measure. First, looking at that group comparison between ICANN and waitlist control prior to waitlist getting that intervention. The only significant difference between the groups that we saw was their anger responses to the EP scenario. So that ICANN group, their anger responses to the EP scenarios was significantly less than that of waitlist control participants, but the others were not significantly different. When we pulled the participants and looked at their post-intervention score, the change in their post-intervention scores, we saw significant reductions in overall their total aggression, their physical aggression, their hostility, and indirect aggression. We also saw significant changes in their anger score on the promise anger measure, and as well as their anger responses to the EP scenarios, and then aggression responses to the EP scenarios. We had added, for this specific study, we added that open-ended item for the AIHQ to the EPs. We just kind of use the same format and added it to the EPs to evaluate their aggressive response. And as far as the global impression of change scores on anger and aggression for the patient PGIC, we saw that 45% found there to be a noticeable change. And when it came to the caregivers, we saw about 40% felt that there was a noticeable change in their anger and aggression. Here are some qualitative comments back from our participants. Some comments that they made is, I do think more before I say something or before I volunteer something. I notice sometimes in certain situations and certain topics that trigger frustration, I'm able to employ the ICANN strategy with other issues. I'm more understanding of people. I don't jump to conclusions. More tolerable of others, delay in actions, increase of processing time, more aware of other people's perspectives, and have improved not just reacting. Notice when I'm driving and another driver does something stupid, I think of reasons why they did it and I don't get so mad. I have been in a better mood over the past few weeks, able to stay calm, not having yelled at my dad. So some really nice comments back from our participants. As far as the limitations and challenges with this study, obviously the sample size was, we were underpowered, no doubt, and attendance was very challenging. So we didn't get the full attendance that we were hoping for. Challenges, As I said, our subjects were on the more severe side of a traumatic brain injury, and some of these exercises were quite abstract. So eh, some of them had a little bit of difficulty with grasping how to execute the exercises, and the therapists, the very skilled and talented facilitators that there um, were able to make some minor modifications to assist with being able to participate in the exercises. Obviously, COVID was a huge issue. And the other challenge too, I think what's exciting is that we got the results that we did in just 6 sessions, but it's really hard when you're doing a group therapy that requires a lot of trust and vulnerability. And there's only 6 sessions. They're just kind of getting to know each other, and the group is sort of ending at that point. So we hope to kind of modify some of the stuff with ICANN to make it more accessible to people. We are currently incorporating the ICANN intervention in a grant that we have right now with the Department of Justice, where we are it's part of a larger, more comprehensive intervention that we are doing with criminal offenders who are being released from prison, who have a traumatic brain injury, and they're up for being released from prison. And we're doing this intervention with them where we're giving them, teaching them coping skills, doing ICANN with them, and then resource facilitation. We're providing them with a variety of resources after they get released from prison. With the idea that this intervention will reduce recidivism and violent offenses. We do realize that I think that these preliminary findings are supportive enough to support the rationale for a larger trial to compare this intervention with a true controlled condition, to look at maintenance of effect over time, and to look at who may be responders versus non-responders, and the level of cognition to benefit in this type of intervention necessary. Out of this work, we did one of the things to disseminate findings from this research. We did work with Brainline. We put together, they helped to create this tip card based on the principles of ICANN called the power of the pause, and using that acronym to sort of to work with those principles of ICANN. So if you're interested and you want this tip card, just go to Brainline to find it and disseminate that with your patients as necessary. I do briefly, I know we're getting close to time and I want to leave time for questions, but I do think, so now I'm hoping that you're all super excited and believe in the importance of these negative attributions after brain injury and the importance of incorporating evaluation clinically with your patients. So how is it that you measure attributions? Before I introduced to you the UP scenarios, the AHQ scenarios. Not a lot of work or no work had been done looking at the psychometric properties of these measures in the TBI population. So we did a comparison of these two measures, and the aims were to look at what's the construct validity of these two measures, and by construct validity, looking at the strength of the attributions and their anger responses. So internally, how was their construct validity, and then compared to one another. We also wanted to see what was their predictive validity. Do these measures predict trait aggression in people with brain injury? And so how well do they do that on their own compared to one another? And then what would the cutoff scores be to be sensitive enough to predict trait aggression accurately in individuals with brain injury? And then we also want to look at kind of more logistical comparisons between the measures in terms of how practical, so the practicality of administration, so readability statistics, administration time, et cetera, between the scenarios. So this is looking at that construct validity. So what's the relationship between the attributions that they made and their anger responses? And on the left-hand side, you're going to see that you're just going to see something, all scenarios combined. That means looking at all of the scenarios in that measure. And then you're going to see where it says ambiguous scenarios. Because of the principle of negative attribution bias, there's a huge crux around the ambiguous scenarios and how people respond specifically to those. And because of the amount of time involved with administering these measures, there is an impetus for wanting to see if it would in fact work to just assess people's responses to those ambiguous scenarios. That's why you're looking at all scenarios combined and then ambiguous scenarios. What we're seeing for the AHQ, the relationship between their attributions and their anger responses is anywhere between 0.39 and 0.65. That's for the all scenarios combined. When you look at the ambiguous only scenarios, a correlation between 0.49 and 0.71. So some moderate to strong correlations there. When you look at the correlations of these attributions with anger for the EP scenarios, you're seeing for all scenarios 0.7 to 0.74, for all scenarios, and ambiguous scenarios from 0.61 to 0.74. So you're seeing fairly strong relationships there. So you're seeing significant relationships for both of those measures. However, the EPS, this construct validity is significantly better in the EPS than it is in the AHQ, although it exists for both of them. So next we wanted to look at the measures ability to predict trait aggression. And I know this is a very busy slide, but I'm going to break it down for you. So that prediction is based on the AUC score, the area under the curve. Essentially, for a measure to be able to predict trait aggression, you're looking at, so you want scores to be at least of a 0.6 or higher to be sufficient, good, or very good, or excellent, to be kind of worthwhile. Again, you're seeing scores for all of the scenarios combined, and you're looking at comparisons between the AIHQ and the EPS for intent and blame and composite scores, etc. So what we're actually seeing is that the prediction ability of this measure for trait aggression on the Bus-Perry trait aggression, that our scores are falling in this sufficient to good range for both measures, regardless of whether or not you're using intent or blame or hostility or the entire measure. You're also seeing that when you compare the AHQ to the EP scenarios in terms of its predictive ability, we're not seeing that these two measures significantly differ from one another, meaning that both measures are similar, perform similar in terms of their ability to accurately predict trait aggression. And then we have your cutoff points, which are giving it, when you use these cutoff points, what we're seeing is that the AIHQ, or I'm sorry, the EPS is a little bit more sensitive in that it is better at more accurately detecting trait aggression when present, versus the AHQ is conversely a little bit better at specificity at classifying somebody not aggressive who's not aggressive. So there's a little bit of a trade-off. In terms of readability and administration, comparatively, the AHQ has fewer scenarios compared to the EPS. It takes the AHQ less time, almost 18 minutes compared to almost 30 minutes for the EPS. The AHQ has fewer words per scenario compared to the EPS, and the reading ease and reading grade level is less for the AHQ than the EPS scenarios. When you want to look at the overall summary, if you're clinically trying to, or research-wise, trying to make this decision, what do I use? Do I use the EPS or the AHQ? I think there seems to be support for using either. It really depends on kind of what your overall purpose is for using it, and whether or not you want there to be more sensitivity, more specificity, whether or not you're using it clinically. So there's a variety of things that both measures are showing adequate construct validity, and predictive ability for trait aggression. However, the EPS is a little bit stronger in construct validity. They're both similar in predictive, their prediction ability. The AHQ is easier in terms of administration and readability. And then finally, if you really want to cut down on time and just administer the ambiguous only scenarios, the results support the use of just using the ambiguous only scenarios without using the full measure, that they're going to still be valid in what you're finding from them. So in summary, kind of the take-home points here is negative attributions are associated with anger and aggression after traumatic brain injury. that people with TBI do have an increased risk for negative attributions and negative attribution bias. And that the factors associated with that seem to be social inferencing and trait aggression. Negative attributions should and can be measured clinically in your patients, and when you're thinking about kind of approaching and addressing their anger and aggression, finding out if attributions are a part of one of the factors that might be contributing to it and addressing that issue. ICANN does seem to show preliminary promise, and excitingly, only after 6 sessions, like I said earlier, it seemed to be feasible. Participants are largely satisfied. The effect sizes, when we're pulling the subjects that we had some fairly good effect sizes for reducing the attributions and reducing their anger and aggression. And there's some indication to suggest that we're getting a little bit better at perspective taking, and maybe it's at least the global impression of change is suggesting that they're getting better at perspective taking. The other measure we're using, the interpersonal reactivity index, may not be as sensitive as we had wanted to be to capture changes in perspective taking. But overall, again, some nice preliminary findings that we're quite excited about. And with that, I just wanted to take some time to acknowledge all of our contributors in this research, co-investigators, contributors, or the research team, the people who are doing the recruitment, the assessment, our clinicians, our participants, and obviously the funders. So with that, I just want to say thank you for your time and attention. Here's my email address. I'd be happy to take any questions or comments now, but also if you want to email me, follow up. As I mentioned, these measures, you have access to these measures. I have been given permission from both of the authors of those measures to share those measures. So if you're interested in accessing either the EP scenarios or the AIHQ measures, or both, let me know, and I'm happy to send them to you, make them available.
And we have just over 10 minutes remaining in the session for questions and answers.
Awesome. I know it's a little bit awkward to be interactive in these types of situations and stuff. And I know it's kind of a long Zoom day and Zoom fatigue and everything. So, but I'm always curious. I love giving this presentation in person because it usually generates tons of discussion. And I always love to hear, people's experiences clinically and what they're dealing with, if this is something that you commonly are find in your clinical practice, and if it, this makes sense, if it's relevant.
Looks like somebody typed, I may have missed it, but did you conduct any follow-up assessments to evaluate the lasting effects of the intervention? If not, any thoughts on that?
Mm-hmm. We did not do anything to evaluate the lasting effects. It was only a 2-year study, and it was hard enough to recruit the subjects and get them tested. It was so long to recruit a wave and then conduct the study, the 6 weeks for the intervention for the one group. And so we really ran out of time of evaluating any maintenance of effects and money to be able to do that. So it is a huge limitation. I am extremely curious what those, if there are any maintenance effects. I do think that that's absolutely the next step in our research and being able in looking at something like that. And I do think that it's important to even think about kind of treatment dose. I mean, 6 sessions is not very long. Being able to look at kind of dose and maintenance of effects, I think would be really interesting to explore.
Another question is, what is anything you would do differently other than evaluation if you could do it again?
Anything differently with evaluation?
Other than evaluation.
Other than evaluation. Yeah, so I mean, yeah, I think that's a hard question. I think that, I mean, I think it's important to sort of have some quantification as kind of understanding and evidence as to what might be sort of contributing. And so I think that evaluation is really helpful. So you may be able to interact with patients and you may have an inkling or a suspicion that somebody has negative attributions. And, you know, you can just tell from kind of the things that they say, the behavior, kind of paranoid type comments, that you could feel fairly certain that this might be something that somebody has. But I think that it's always important to have that evaluation to confirm that, and then to be able to measure change. So, I mean, kind of, I think, you know, that functional behavior is also extremely important, as well as that the evaluation as well. And I'm not sure I'm getting at that question, so I apologize if I'm missing the point. If you want to ask a follow-up question, if there's something additional to that, happy to answer more.
We have a couple more questions coming in. Is there any intent to trial this in the pediatric population?
That's a great question. I don't work with children with traumatic brain injury, but there is an abundance of literature on negative attribution bias in children, non-TBI. So there's quite a bit on that. So yes, people are doing that, not necessarily with this intervention. Obviously, this is brand new and specific to TBI. And I haven't looked at that literature in a little bit, but there's definitely stuff in the pediatric literature on this. Absolutely.
Is there consideration for how this intervention can be applied in individual treatment versus group?
I love that question. So it's really interesting. You have people that are very strong supporters of group therapy, as was the original creator of this. I don't think I mentioned her name. I should have given her credit before, Jill Weingartner and Layla Prince and Claire. They're very huge supporters of group therapy, and I definitely see the value of group therapy and participants being able to learn from each other and observe things. I also see that there's a lot of value into being able to do things individually and have more time to work with people's specific issues. If I were to have the best of both worlds, I really would recommend having almost a hybrid of individual and group therapy with this.
And we still have 5 minutes left to answer questions. There's one in the chat box and 2 in the Q&A box.
Yeah, I'm seeing them. I don't know if you guys, since I'm screen sharing, I just realized that you guys might actually be seeing those questions that are popped up on my screen. I'm not sure if you can or not. But one of them is, do you happen to know of any support services agency strategies that can help elderly clients with negative attributions? Yeah, I think it's an interesting question, because I mean, if the question's about elderly clients without TBI, you know, my world is so solely focused on traumatic brain injury that I wouldn't necessarily know that. If you are talking about clients with brain injury, you know, this is all brand new stuff, although I'm sure many of you sense that this is very familiar also to, well, this intervention is different, but I mean, the idea of negative attributions and cognitive behavioral therapy and kind of that reframing of appraisals. So, okay, so he has a TBI, 92 years old. Wow. Yeah, I think that a program, it would be interesting to kind of work with this patient and kind of do a case study and, work one-on-one. I think that it's still a little early. Like I said, this is a very preliminary phase 1 sort of trial. So we're still we have a lot to learn about this. So a little hard to say about how this works in older people, younger people, all kinds of things that we don't really know. But I do think that it might be interesting if you are working with a patient who has exhibiting these types of signs, to be talking about bringing up some of these things and going over, even just having the assessment and kind of going over and seeing the person's responses and kind of talking through that with the person and brainstorming ideas and reevaluating. I think that it certainly would be worthwhile to pursue doing that. But still so much that we have yet to learn from it. And then also we see, there's another question. I'm not sure if you clarified, but what was the traumatic brain injury defined stroke? This was specifically TBI, so not stroke. So it was most of our TBIs were from car accidents and falls, but they were traumatic brain injury. So no stroke, no hypoxia, anything of that. I think we did include gunshot wounds as well. I know sometimes we don't always, but I think we didn't exclude people who had gunshot wounds. It was any traumatic brain injury. All good questions. So hopefully from these questions, it seems like this is something that, you guys have experienced and can relate to. Yeah, so do we plan to conduct another study? Yes, hoping that we can get some additional funding through NIH. That's the plan, to write an R01. This was an R21 study funded through NIH. So kind of thinking through the next steps for an R21, where we would be doing with a larger sample, with, again, trying to do, looking at maintenance effects, which was that question earlier, and really kind of understanding who can respond or not respond to the treatment. What factors contributed to the person's anger, hostility? So as far as what factors contributed to their anger, all we know, so we evaluated, we do have other information. So we evaluated we evaluated social inferencing, we evaluated perspective taking, we evaluated all of these things. We're still at a plan this is literally hot off the press, and because we have such a small sample size, it's really hard to know exactly, but because all of our subjects had to have both anger and negative attributions, the concept of this study was that all of these subjects in this study had negative attributions that were contributing to their anger and aggression. Were there other things that could be contributing to their anger and aggression? Absolutely. However, we have not had time to look at kind of other covariates in terms of their cognition level, or other factors that may have been contributing to it, fatigue, whatnot. But we know for sure, because that was an inclusion criteria, to have negative attributions along with anger and aggression, that was likely to be the factor contributing to it. And then this last question, do you foresee doing studies on these folks who have had COVID and brain injury? That's a very interesting question, such a timely one. Yeah, I think I don't know. I hadn't really thought about it. I know that there's long COVID. I know people are having attention problems, memory problems. I have to say, I don't know. I have not been following a whole lot of the literature on patients with COVID and emotional deficits and anger and aggression. I think that would be really interesting to see. I don't know if you guys are familiar with that. So I think that this type of intervention is appropriate for people who have anger and aggression that's related to negative attributions.
Last thoughts?
Last thoughts, like I said, please email me if you have any additional questions. I really appreciate your time and attention. I hope you guys enjoy the rest of the conference. If you are interested in accessing these measures and seeing what they look like, I am happy to send them to you. And thank you so much for having me. I appreciate it.
Thank you so much.
Absolutely. Should I just stop screen share now?
Yes, this concludes our first session of the day. The next session will begin at 12 o'clock. And please do remember to check out our exhibitors, our student posters, and to fill out your evaluations and your post-tests if they're needed. Thank you again for a fabulous presentation. Everybody enjoy the rest of the seminar and reach out to Dr. Newman if you do have questions. Have a wonderful day.
Hi, everybody. Thanks.